and I really appreciate that. With that, I am going to introduce our first content speaker. Dr. Charlotte Loppie is a professor in the School of Public Health and Social Policy and director of the Center for Indigenous Research and Community-Led Engagement, University of Victoria. Dr. Loppie's research partners have included individual First Nation communities, regional and national Indigenous organizations, as well as provincial and national government stakeholders. She's undertaken research and published in many areas, including Indigenous health, Indigenous HIV and AIDS, social determinants of Indigenous health, racism, cultural safety, Indigenous ethics, and research capacity building, as well as sexual and reproductive health of Indigenous women. And certainly we're very privileged and very honored that she was able to join us and give us her knowledge and wisdom today. And so with that, Dr. Loppie, I'm going to turn it over to you.
Thanks, Diane. I just also wanted to thank the folks at Health Promotion Canada for involving me in the book and in the project, and as well as the folks from the National Collaborating Center for Determinants of Health for hosting this webinar. It's great to be here. Hopefully this presentation will help folks in the work that they do. Yeah, so I first wanted to acknowledge that I am a grateful visitor here on the territories of the Songhees and Esquimalt peoples, as well as the Wasanic peoples. Those are the First Nations whose territories the University of Victoria sits. And so, yeah, today I'm just going to talk a little bit about the chapter that I wrote for the book entitled Indigenous Health Promotion. If you could move to the next slide. So just in terms of context, I'm sure a lot of folks that are listening are familiar with these contexts, but it's important that we acknowledge them before we start to talk about how we engage with Indigenous peoples in terms of health promotion. And so the term Indigenous is being used more frequently now to refer to folks across the globe, but in particular Inuit, Métis, and First Nations people in Canada. The term Aboriginal is still being used by some people, and some folks don't use either of these, but the term Aboriginal peoples is part of the identification of the First Peoples in the Canadian Constitution, so just important to understand what those terms mean. But it's also really important to understand that there is great diversity between these groups of folks in Inuit, Métis, and First Nations, but within those groups as well. And so that diversity spans traditional lands, languages, cultures, to name a few, but also colonial experiences. And so for each group there's been a different distinct historical relationship with the land, or with the government, but there are some similarities. And so in terms of understanding that the folks that we engage with have undergone a process of colonization, which will impact likely the relationships that we have with them. So it's important to understand that people have experienced and continue to experience the consequences of dispossession of their lands, the imposition of colonial institutions, and that includes the institutions in which we work, as well as disruption in traditional lifestyles and practices. But that doesn't mean that people aren't still interested and engaged in those practices. It's also important to understand that for the most part, and in particular First Nations and Inuit people, the health promotion that is delivered to them either on reserve or in Inuit hamlets and communities is generally implemented through the federal government's First Nations and Inuit health branch. So again, these are the political. One of the things that, for me, this is something, I teach in public health, and so I interact with lots of folks who are actually working in healthcare and in health promotion. And again, one of the one of the really critical things for people to remember is that colonialism, colonization, colonialism has shaped those inequities. Most of you will be very familiar with, World Health Organization's definition of the social determinants, and they make it very clear that is political decisions about resources and power or control that shape equity or inequities, right? And so it is those decisions and that relationship with the state that really does shape most of the inequities that are facing Indigenous communities. There are local, regional, and national distinctions, but there are also similarities. It is the responsibility of the health promoter or health promotion agency, department, organization to know those local, regional, and national distinctions and similarities, particularly around culture, language, but also the kinds of inequities and how they've been shaped in community. I'm using the term supports here in place of interventions. Interventions is a kind of a very blunt term, and I think language is important. And so when we start to talk in relation to supporting Indigenous peoples and communities and nations, I think we can start to think about ways that we support rather than intervene, because intervening is part of the problem, right? So it's important that those supports are designed, implemented, and assessed within the most appropriate cultural context that is appropriate to the local, regional, or national context within which we're working. So if we're working with a local community, then we need to understand the cultural context of that community. If we're working nationally, then we need to understand the diversity that we're going to be facing, and that's an important point in our discussions. And so I wanted to just talk about a couple of really important determinants of health when health promotion or health practitioners and health professionals are working with Indigenous people. The first is, again, the critical role that colonization has played. And I want to make it clear what we're talking about when we say colonization. We're not just talking about settling. So when we settle somewhere, if I move to another country, I learn the language of those peoples, I follow the laws of those peoples, I adopt the customs and traditions of those peoples. Colonization is establishing control and rule and dominating another people. So when we talk about colonization, it's not a historical, it is a historical context, but it's also a current context because the institutions and our relationships are one that evolve out of this notion of colonization, and that's why you'll hear Indigenous peoples talking about colonization and colonizing practice as a really important social determinant of health. The next is structural racism. I'm not going to go into length because I know there's a future seminar about this. But again, for folks who are working in health promotion and public health, it's really important to understand the historical and social and political institutions and processes that not just practice racial discrimination, that is anti-Indigenous racial discrimination, but they also create and reinforce that through policies like the Indian Act. I mean, the Indian Act is a very clear example of racial discrimination. The Indian Act is a racist act. It is only referenced to Indigenous people referred to as Indians. The non-insured health benefits program is one that is, again, it is implemented or administered through the state. And then there are a number of, and I can't get into jurisdictional issues that folks encounter in terms of lots of different institutions within their relationship with the state. The other is historical, but it's it's not like it's ended, right? And that is the location of many Indigenous communities, particularly Inuit communities and First Nations communities that were established in particular places for particular reasons that didn't have much to do with the benefit of those people, as well as the funding for those communities with respect to the relationship they have with the state. I hope I don't have to tell anybody about residential schools or Indian hospitals, but those two institutions, which lasted decades and decades and decades, had a profound effect and continue to have a profound effect on the health of Indigenous people. And then the final one is really important because we generally, hopefully, depend on research to inform the development of health promotion and public health policies and practices. If that research is pathologizing to Indigenous peoples, if it is not conducted with for the benefit of Indigenous peoples, then that evidence is corrupted, and that means we're informing our practice through poor evidence, and poor is probably the least pejorative word I would use for that. Also important for folks that are just learning about working with Indigenous peoples in a good way is really the constructions of health. And this is again, very brief overview. First is that, every culture has belief systems and knowledge systems. And so within many Indigenous peoples, and again, these are broad generalizations, but they are common themes among different Indigenous peoples and cultures, is relationality, and that's an important thing that I'll come back to later. But the relationship we have with communities and organizations, Indigenous organizations, is critical to working well together and ensuring that everybody is meaningfully engaged, right? Reciprocity is another really important thing. It's not enough to just take from communities. It's about sharing our strengths and their strengths. It's about helping one another to move forward in a good way. And then the notion of subjectivity as part of a belief system is that everybody sees the world in a different way, and it's not necessarily a good way or a bad way, particularly when we're talking about differences in cultural values, right? So lots of folks tend to think that the dominant way of seeing the world and viewing health is the only way, and that's a pretty dogmatic way of thinking, and that's not the way that a lot of Indigenous people think. The other important one, I'm sure most of you are familiar with, which is this notion of holism, and that means that it's important for people to try to create balance, not only within different dimensions of health, but between those dimensions, and not focusing solely on one thing. And the importance of those dimensions as situated or located within kinship networks, community networks, cultures, and very importantly, place, right? And so these are not simple things. These are not easy to sort of, concepts aren't easy to use, but they're really important to use. And then the final one is pluralism. It's not final. There's lots of other ones. And this is around really valuing that there are diverse ways, that Indigenous cultures and communities have lots of important teachings to share with non-Indigenous health promoters and professionals, and that when we draw on all of our strengths and we work together to overcome individual limitations, we actually move forward in a better way, and communities benefit from that process. And I would argue so do health promoters and health professionals. So just the last few slides really are focusing on this notion of health promotion and Indigenous peoples in Canada. And I want to talk just briefly about, if we talk about decolonizing or, working toward reconciliation, we have to first talk about what's the issue we're trying to address, right? So if we think about this term like colonizing, and again, if we go back to colonization, what does that mean? It's not just about colonizing land. It's about colonizing knowledge. It's about colonizing ways of doing things. It's about coming into community uninvited with no relationship, right? And so it's about not consulting or engaging with community, particularly leaders and elders and knowledge holders, about what is the best way to pursue addressing the needs of those communities. And those supports really need to be based on, they normally are based on someone else's values and context. And so, people are always looking for ways to generalize or create these sort of larger projects that can be administered across the country or across a region, and that just doesn't work, right? And so if we're developing those supports within a context that is not relevant to a community, then the supports are implemented and they're evaluated in ways that are not relevant to the community. And then we wonder why they're not working, right? So those are examples of ways that people are colonizing in their health promotion. To decolonize, first is recognize our own. So first of all, recognize some of these things I've talked about, which is the impacts of history, traditions, values, families, and communities. But it is also, someone's moving around, I'm not sure who. It is also the importance of understanding our own social position in, not just in our work, but in the world, right? And so I encourage all of my students and everyone I do these kinds of workshops with is, who are you, right? What were you, what racial group or racialized group were you born into? What gender? What sexual orientation? What social class? Know yourself. If you know yourself and you understand how the values that you've been raised with, but also the privilege that you've been raised with, how that might have and likely has influenced the way you think and you do, then you'll understand that Indigenous people are also influenced by those external forces over which we have no control. So people often say, well, I want to learn about Indigenous people so I can do good work. It's just as important to understand yourself in the context of that work as it is to understand the forces that have shaped Indigenous people's health and that continue to shape health and engagement in community, right? And so I like this, the quote underneath that, which is that in these authors' perspective, that the process of decolonization is really about creating, restoring, and birthing new ideas, thinkings, technologies, and lifestyles that contribute to the advancement and empowerment of Indigenous peoples, right? So it's not about doing for or even sometimes doing with. It's about giving over resources, power, and working in service to community. And so there's some examples, right? And so decolonizing processes are ones in which community has control, and that is whoever is engaged with these processes in the community that has a designated authority to engage with health promotion and public health, that they and community members that want to are in control of the development and implementation. And that doesn't mean complete control. It means that they have a major say and that they are meaningfully engaged, right? And engaged in ways that are congruent with those communities' values and the context in which they are trying to pursue the health and wellness of their community members, right? That this process has to be relevant and beneficial to the community from their perspective, not from the health promoter's perspective. And again, getting back to the notion of cultural relevance, right? It means that health promoters must understand the local perspectives, right? And address those perspectives and the context within which this health promotion is occurring. So it means you have to understand the community or the organizational or the cultural needs of the folks that you're working with. This is the last slide, and it really is, for me, the key, right? And that is understanding that self-determination is the route to wellness among Indigenous peoples, right? And so the UNDRIP talks about this. It says that Indigenous people have the right to be actively involved in developing and determining health and programs affecting them, and as far as possible, to administer those programs through their own institutions. Similarly, the TRC calls to action are very clear that supports need to be based on values of equity. Equity is not equality. It is justice, right? It is that line of social justice, and that are aimed at influencing, or reducing rather, the influence of these colonial practices. And again, this has to be the sort of foundation of the way we pursue public health and health promotion with Indigenous communities. So I wanted to thank you all. Hopefully I didn't go over my time. I am looking forward to hearing the next presenter.
Oh, thank you so much, Charlotte. No, you didn't at all go over your time. That was really, really excellent.
Okay.
I'm going to go ahead.
I'm just going to mute my line now.
Oh, sure. I'm just always so struck at how I learn something different about this every time. And I worked in public health practice for a long time, and I'm just really pleased that this is becoming more of a priority for everyone. And someone made a comment during your discussion about looking at our own positionalities. And so that's a really interesting thought for me. My practice and then health. That affects my world. How that affects